Okay, imagine this. You're just starting out in your clinical rotations. Patient comes in, looks like a minor cut, Sybil's great. But then, hours later, it just escalates. Fever spiking, blood pressure dropping. Suddenly it's a full-blown emergency racing against the clock. So what happened? What changed so fast? What unseen forces were playing out there, turning something routine into, well, a life-threatening crisis? Today we're doing a really critical deep dive. We're going into the incredibly diverse, often surprising, sometimes terrifying world of infection, going microscopic, zooming right in on the players, their strategies, and how our body fights back, sometimes in ways that damage itself.
Absolutely. And our mission here in this deep dive, it's really to equip you, our future clinicians, with the essential stuff, the foundational knowledge, those mental anchors you need, and the critical thinking skills. Skills you absolutely have to navigate the complex landscape of infectious diseases. Think of this as your foundational map, maybe, to the microbial universe. We're focusing on what really matters most for your clinical journey ahead. Every concept, every example, every detail we talk about today, it's chosen because it will help you connect the dots later in a real clinical scenario, hopefully give you those aha moments that make knowledge stick, and let you act decisively.
Exactly. We want to build you a really robust framework. We'll break down everything, from the tiniest viruses and bacteria, understanding how they work, how they spread, and crucially, how our bodies fight back, or sometimes how they get overwhelmed. We'll also look into how these microscopic things adapt, constantly challenging our best treatments, our best strategies. So from that first point of microbial contact all the way to global health challenges, this deep dive is your essential high-yield companion for really understanding infection.
Okay, so let's start by meeting the main characters. In our microbial menagerie, when we talk about microorganisms that cause disease, we're looking at an incredibly diverse cast, a real mix. We have the true microorganisms, things like bacteria, archaea, fungi, protozoa, and helminths, those are your parasitic worms.
Right. And then there are a couple of, let's say, notorious troublemakers.
Right.
They aren't technically microorganisms in the strictest biological sense, but they are incredibly important pathogens we have to understand. Talking about prions and viruses. So if you think about it like maybe a neighborhood watch.
Yeah.
Some are the full residents, the true microorganisms doing their thing. Others, like viruses and prions, they're more like notorious visitors popping in. But their ability to cause chaos, just as significant, maybe even more so sometimes.
Yeah, that's a good way to put it. And there's a really fundamental divide that separates many of these players. It's whether they are prokaryotes or eukaryotes. Now, this distinction, it might seem a bit academic at first, but it profoundly impacts how we target them, with treatments, I mean. Prokaryotes, which include bacteria and archaea, they're unicellular, and they lack a true membrane-bound nucleus. Their genetic material isn't neatly packed away. It's usually in a region called the nucleoid. And they don't have other membrane-bound organelles either.
Okay, so to really picture this, imagine a cell as a house. Prokaryotes are like studio apartments, right? Everything's just in one open space. No separate rooms, no distinct kitchen or bedroom. It all just happens in one main area. Eukaryotes, though that's your fungi, protozoa, helminths, they're the grand houses. They've got distinct, dedicated rooms. Those are the organelles for specific jobs. And they have that dedicated control room, the nucleus, holding all the genetic blueprints. This difference, this studio apartment versus grand house idea, it's really key. It directly tells us how we can design and use antibiotics or antifungals, because you're dealing with either a simpler open-plan setup or this complex compartmentalized mansion.
Spot on. Now, let's really shine a spotlight on bacteria, because they are tiny, yes, but incredibly mighty and absolutely central to so much you'll encounter clinically. Bacteria are unicellular organisms found pretty much everywhere. Deep oceans, our own skin. We name them using binomial nomenclature, a genus and species name, like Staphylococcus aureus. Or we just say S. aureus for short, once the genus is clear.
And classifying them is so crucial for knowing how to fight them. One of the first things we look at is their morphology, their shape. You'll mainly run into three basic shapes. You've got cocci, they're spherical, like tiny balls. Think Staphylococcus aureus or Streptococcus pneumonia. Then there are bacilli. These are rod shapes like little pills, classic examples. Escherichia coli, Pseudomonas aeruginosa, and finally the spiral bacteria. As the name suggests, they've got this curved or corkscrew shape, like Treponema pallidum. So to really anchor that in your mind, cocci are spheres, bacilli are rods, and spirals. Well, they're the corkscrews of the microbial world, distinct, memorable.
Right. And beyond shape, we classify bacteria by their oxygen needs, which is critical information for predicting where they might cause trouble in the body. Aerobic bacteria, like Mycobacterium tuberculosis, the cause of TB, or Pseudomonas aeruginosa, they absolutely need oxygen to grow. Anaerobic bacteria, conversely, like Clostridium botulinum or Bacteroides flagellis, they grow only without oxygen. They get their energy through things like fermentation or anaerobic respiration.
And then you've got the really adaptable ones, the facultative anaerobes,
Yeah.
like Escherichia coli and Staphylococcus aureus. These guys can grow with or without oxygen, makes them incredibly versatile, often widespread pathogens. The clinical relevance here is huge, right? If you suspect an anaerobic infection, you're looking for it deep in tissues, maybe in abscesses, or in areas with poor blood supply where oxygen is low, like a diabetic foot ulcer. Knowing this immediately guides your diagnostics, your treatment choices.
Exactly. And a cornerstone diagnostic test, one you will use again and again, is Gram staining. It's a sequence of dyes crystal violet, iodine, alcohol, safranin, and it exploits a fundamental difference in the bacterial cell wall structure. Gram-positive bacteria, like S. aureus and Streptococci, they have a thick peptidoglycan layer, but they lack an outer membrane and lipopolysaccharide, or LPS. Because of that thick wall, they hold onto the crystal violet dye and stain blue or purple.
Whereas gram-negative bacteria, like E. coli and Salmonella, they have a much thinner peptidoglycan layer. But crucially, they have an outer membrane that contains LPS. This outer membrane means they don't hold on to the crystal violet after the alcohol wash. So they pick up the pink or red counterstain, the safranin. The metaphor here is really powerful. Think of the gram stain as a secret decoder ring for bacteria. Gram-positives have that thick wall, holds the purple dye like a sponge, keeps its color. Gram-negatives, thinner wall, but that extra outer shield lets the purple wash out, and they take up the pink. This color code, it tells us almost instantly what kind of defense system we're facing, which directly informs our initial antibiotic choices, because different drugs target different wall components, especially peptidoglycan, that rapid information. Invaluable in emergencies.
Okay, moving beyond bacteria, there are other key pathogens critical to understand. Fungi, for instance. They mainly come in two forms you'll encounter clinically: yeasts and molds. Yeasts are unicellular, kind of round or oval cells. They reproduce by budding or fission. Candida albicans is a prime example you'll see often. Causes things like oral thrush, vaginal candidiasis, and in more severe cases, bloodstream infections, candidemia, especially in people who are immunocompromised.
And molds, they're different. They're multicellular, grow as these filamentous structures called hyphae, which can be septate or non-septate. Think of Aspergillus, a common cause of respiratory infections. Clinically, recognizing fungal infections like oral thrush in vulnerable patients, maybe someone on steroids or antibiotics, is super common and vital for quick treatment.
Then we have helminths and protozoa. Helminths are larger multicellular organisms, basically worms. They can be free-living or parasitic. You'll encounter things like tapeworms, hookworms, pinworms. Protozoa are single-celled eukaryotes. Many are significant pathogens, like Plasmodium species causing malaria, Toxoplasma gondii causing toxoplasmosis, or Trichomonas vaginalis, a common STI.
And finally, those fascinating non-living infectious agents. Prions are maybe the strangest. They're just misfolded proteins, no DNA, no RNA. They cause disease by converting normal cellular proteins into their misfolded pathogenic form. This leads to these neurodegenerative diseases called transmissible spongiform encephalopathies like CJD, Creutzfeldt-Jakob disease. Gives the brain that characteristic sponge-like look. What's really astonishing and, frankly, terrifying is that prions are incredibly resistant to inactivation by normal methods. And because they're basically altered versions of our own proteins, they don't even trigger a normal immune response.
Then there are viruses. Also not considered living in the usual sense. They're just genetic material, either RNA or DNA, wrapped in a protein coat called a capsid. And crucially, viruses absolutely need a living host cell to replicate. They're cellular hijackers. Almost all of them are pathogenic. They can be enveloped or unenveloped, very hugely in shape.
Right, so to cement that idea, think of viruses as cellular hijackers. They don't have their own factories, their own machinery, so they invade your cells and take over your cellular machinery to make copies of themselves. Prions are even weirder, like a rogue instruction manual that corrupts all the good ones, silently spreading bad info and causing problems inside the cell. Some key DNA viruses, herpes simplex, varicella zoster chickenpox and shingles, and human papillomavirus, HPV. For RNA viruses, big players like HIV, influenza, and of course coronaviruses like COVID-19, SARS, MERS.
Okay, so we've met this fascinating cast of characters. Let's get into part two, the art of invasion, how infections happen. First, some really essential definitions for your clinical vocabulary. Infection happens when pathogens successfully enter the body and start multiplying. A pathogen is specifically an organism that causes damage to the host. Important to remember, not all microbes are pathogens. Many are beneficial commensals. Pathogenicity is just the ability of a microorganism to cause disease. And disease itself occurs when the recognizable signs and symptoms of illness appear.
Yeah, and not all pathogens are created equal either, right? This has huge clinical relevance. You have opportunistic pathogens. They don't normally harm a healthy person, but they cause disease if the host becomes susceptible, maybe a weakened immune system like an HIV or someone on chemo. Staphylococcus aureus is a classic example of an opportunist. Then you have primary or true pathogens. These are tough enough to cause disease in pretty much any susceptible host, healthy or not. And remember, infections can show up in lots of ways. Sometimes no symptoms at all, subclinical, or dormant, latent, or acute, rapid onset, or chronic, dragging on, localized to one spot, or generalized all over.
Exactly. And how well a pathogen thrives depends on its inherent pathogenicity, its degree of virulence, meaning how harmful it is, its capacity to cause severe disease, and its invasiveness, its tendency to spread through host tissues. This brings us to a concept that's crucial for every clinician, especially in infection control, the chain of infection. It's a cycle, a model with 6 interconnected links: the infectious agent, the reservoir, the route of exit, the mode of transmission, the route of entry, and finally, a susceptible host.
And here's a really powerful anchor for your memory. Think of this chain of infection like a game of telephone, but for disease. Each of these 6 links must be present and unbroken for the message of the infection to get passed along successfully from one host to the next. The huge clinical insight here is if you can break any single link in this chain, you can stop the spread of infection, full stop. Whether it's blocking the exit, changing how it's transmitted, strengthening the host, understand this chain lets you stop disease.
Let's quickly break down each link. The infectious agent is the microbe itself, bacterium, virus, fungus, parasite. Its success depends on its pathogenicity, virulence, invasiveness. The reservoir is where the pathogen naturally lives and multiplies. This could be a human either acutely sick or an asymptomatic carrier, or an animal or insect leading to zoonotic infections like rabies or Lyme disease, or even the environment like soil for tetanus spores or water for Legionella.
Next up is the route of exit. How the pathogen gets out of the reservoir or host can be through various body fluids or processes: vomiting, diarrhea, biting, sexual transmission, coughing, sneezing, skin lesions. Following that is the mode of transmission, how it travels. This can be direct contact, touching an infected person or animal, sexual contact, or indirect contact where the pathogen survives for a bit outside the host on inanimate objects called fomites, like contaminated clothes or medical gear. Another critical mode is vertical transition from parent to child during pregnancy, birth, or breastfeeding.
Then we have the route of entry, how the pathogen gets into the susceptible host. Common entry points: respiratory tract through inhalation, GI tract through ingestion. Breaks in the skin like cuts or wounds, absorption via mucous membranes, or even inoculation injuries, needle sticks, and medical devices like catheters or breathing tubes.
And finally, the susceptible host. This link is all about the host's condition, their defenses versus the pathogen's virulence. Our normal bacterial flora on skin and mucous membranes actually give us some protection. But individuals with a defective immune response are really vulnerable. They get frequent, recurrent infections, even from less nasty bacteria that wouldn't usually cause harm. Think about HIV/AIDS patients with low CD4 counts, infants with their developing immune systems, the elderly, or those with conditions like cystic fibrosis or physical trauma like burns. Identifying these risk factors in your patient is absolutely crucial for prevention and for early targeted intervention if infection does happen.
Pathogens also come armed with a specialized toolkit. We call these virulence factors. These are specific molecules or traits that let the pathogen colonize the host, evade or inhibit the immune response, and get in and out of host tissues. Examples include adherence factors, like pili, that help bacteria stick to cells; invasion factors that help them spread; protective capsules that stop immune cells from engulfing them, phagocytosis; and famously, exotoxins and endotoxins, which we'll get into more detail on soon.
All right, so to simplify, virulence factors are like a pathogen's specialized gear for breaking and entering your body, deftly dodging your security systems, and then causing maximum chaos once they're inside. Thinking like a detective now. Diagnosing infection requires a systematic clinical approach. As a future clinician, you'll always start with a thorough history, gathering info on the presenting complaint, past medical history, meds, allergies, family history, and a crucial social history, travel, pets, job, potential exposures.
Then we carefully assess the patient's symptoms. Many minor infections are diagnosed just by their classic clinical picture. This is where your observation skills shine, along with a detailed examination using techniques like observation, percussion, auscultation. Finally, investigations. These will vary depending on what you suspect. Could include cultures from blood or swabs, x-rays or CT scans, various blood tests like a full blood count or C-reactive protein, CRP, to check inflammation. This systematic approach history, exam investigations, is the bedrock, the foundation of good medical practice for infectious diseases and really all of medicine.
Okay, let's jump into some real-world examples now with case studies in bacterial pathogenesis. We'll focus on two incredibly common important genera, Staphylococcus and Streptococcus. Let's start with Staphylococcus aureus. This is a gram-positive coccus, spherical shape, and it's a notorious opportunistic pathogen, really famous for causing skin and soft tissue infections, SSTIs. These are incredibly common, make up maybe 7–10% of hospitalized patients, seen all the time in the ER.
Right. And SSTIs caused by S. aureus, they can range from pretty mild things, like folliculitis, to really life-threatening conditions like necrotizing fasciitis. Our skin is our main barrier against infection, so any break-in at a cut, surgical incision, even a minor scrape is a common entry point. S. aureus uses a formidable set of virulence factors. Adhesins help it stick to host cells. Exotoxins and enzymes can be cytolytic, directly destroying cells, or exfoliative, making skin layers peel. And a key factor, coagulase, lets it form a protective clot around itself, effectively hiding from the immune system's phagocytes.
A dramatic and clinically important example of S. aureus toxin activity is staphylococcal scalded skin syndrome, SSSS. This is caused by specific protease enzymes the bacteria make, which break down proteins holding skin layers together. It mostly affects kids under 5. Presents with widespread redness, fluid-filled blisters, bullae, and a positive Nikolsky sign where the top skin layer separates easily with gentle pressure. Patients also get fever, irritability, lethargy. SSS can lead to rapid skin loss, severe fluid and electrolyte problems, issues with temperature regulation. It actually carries a significant mortality rate, about 4% in children.
Another severe life-threatening condition from S. aureus toxins is staphylococcal toxic shock syndrome, TSS. This is an acute illness where the toxins act as superantigens. They activate a massive, uncontrolled release of cytokines from T lymphocytes, leading to systemic inflammation, a cytokine storm. Risk factors include menstruation, especially with tampon use, but also post-surgical infections, burns, or postpartum infections. Patients present with rapid onset fever, a diffuse rash, severe low blood pressure, nausea, vomiting, headache, muscle aches, and critically, multi-organ failure. Management is urgent. Needs specific antibiotics like clindamycin plus oxacillin or maybe vancomycin for suspected MRSA or penicillin allergies, plus aggressive surgical debridement and supportive therapy, usually in an ICU.
It's also really important to distinguish S. aureus from other staphylococci you'll encounter. S. aureus is characterized by being coagulase positive, often produces those distinctive golden yellow colonies in culture. In contrast, coagulase negative staphylococci, CoNS, like S. epidermidis, are coagulase negative. Now, S. epidermidis is a common commensal found harmlessly on our skin and mucous membranes, but has this remarkable ability to form biofilms on medical devices, things like vascular catheters, prosthetic heart valves, joint replacements. This can lead to persistent, really hard-to-treat infections, especially in immunocompromised people. This is a critical point for you as medical students, as these biofilm-related infections are a major cause of problems in hospitals.
Okay, next up, let's explore Streptococcus pyogenes, also widely known as Group A Streptococcus, or GAS. These are gram-positive pochi, usually arranged in chains, and they are almost always pathogenic, characterized by their Lancefield Group A antigen. S. pyogenes causes a huge range of diseases, from relatively mild things like pharyngitis, strep throat, and impetigo, to more severe infections like cellulitis, and even life-threatening conditions like toxic shock syndrome and rheumatic fever.
S. pyogenes also has a pretty formidable arsenal of virulence factors contributing to its diverse pathology. These include streptolysins and hemolysins, toxins that break down red blood cells, superantigens that contribute to excessive immune activation, similar to staphylococcal TSS, hyaluronidase, an enzyme that breaks down hyaluronic acid, a part of connective tissue, letting the bacteria spread easier. Streptokinases break down blood clots, also helping tissue invasion. And a key factor, M protein, is antiphagocytic. helps the bacteria evade the immune system, prevents opsonization, that process of marking bacteria for destruction.
One of the well-known diseases caused by S. pyogenes exotoxins, specifically its superantigens, is scarlet fever. This causes a widespread inflammatory response, usually affecting kids aged 5 to 15. It presents with a classic triad: sore throat, fever, malaise, followed by a widespread, fine, sandpaper-like rash, often with enlarged lymph nodes, and that very distinctive strawberry tongue. Scarlet fever is mainly diagnosed clinically and needs prompt treatment with penicillin to prevent serious complications like acute rheumatic fever or kidney problems.
Cellulitis, that infection of the deep dermis and subcutaneous tissue, is commonly caused by both S. pyogenes and S. aureus. It happens when bacteria get through the skin barrier, maybe a cut, insect bite, or existing skin condition. Clinically, it presents acutely. An area of skin that's red, painful, hot to touch, swollen, often described as having an orange peel look. Patients might also have systemic symptoms like fever and feeling unwell. The management usually involves quick antibiotic therapy, often a combination like benzylpenicillin and clindamycin. Vancomycin might be used for penicillin allergy or suspected MRSA, and supportive care for severe cases.
Finally, let's introduce Candida albicans, an incredibly important opportunistic fungal pathogen. Candida is a yeast that's part of our normal flora, found in the mouth, GI tract, GU tract. But it can become pathogenic, especially in immunocompromised or HIV-positive patients. Causes a range of diseases. Superficial mucosal infections like oral or vaginal candidiasis, to small intestinal fungal overgrowth, and severe systemic bloodstream infections known as candidemia.
Its virulence factors are actually quite sophisticated for a fungus. One key factor is polymorphism, its ability to switch between different forms, specifically from a commensal yeast form to a more invasive, filamentous hyphal form, which helps it penetrate tissues. It also forms robust biofilms, much like bacteria, which helps it persist on mucosal surfaces and medical devices. Plus, Candida secretes various hydrolytic enzymes, like secreted aspartyl proteases, SAPs, and phospholipases. These help it rupture host cells and invade deeper tissues.
A very common clinical presentation you'll definitely encounter is oral candidiasis, also known as oral thrush. This happens when there's excessive fungal growth in the mouth, often predisposed by things like poor oral hygiene, smoking, using oral steroid inhalers, or broad-spectrum antibiotics that disrupt the normal oral microbiota. It typically presents with white patches or plaques on the tongue and oral mucosa. These can often be scraped off, sometimes leaving painful red spots underneath. Patients might also report taste changes, a burning feeling, or inflammation of the tongue, glossitis.
Now, in severely immunocompromised hosts, think patients on chemo, organ transplant recipients on immunosuppressants, or people with advanced HIV candida, can be much more serious. It can go from just colonizing to being focally invasive or even disseminated multi-system infection, causing things like esophageal candidiasis is very common in HIV sepsis, pneumonia, meningitis, or endocarditis. For mild to moderate cases, topical antifungals like clotrimazole work well. But severe infections, especially systemic ones or in immunocompromised patients, need systemic antifungals like fluconazole or amphotericin B. Recognizing the opportunistic nature of Candida is really key to managing these patients effectively. Phew, okay, that's quite a lineup of the players we've met. Now let's move into part 3, and this is critical for every single medical student. When the body fights back too much, sepsis and systemic overload. Sepsis isn't just an infection, it's a life-threatening organ dysfunction that happens because of a dysregulated host response to infection. It's basically your body's immune system going into an uncontrolled self-damaging overdrive.
Exactly. The sequence usually starts with a microbial infection somewhere in the body. This leads to bacteria getting into the bloodstream that's called bacteremia. This can trigger a widespread inflammatory response known as systemic inflammatory response syndrome, or SIRS. Now, SIRS is an inflammatory response to various insults. Could be infection, trauma, major surgery, even a heart attack. But when SIRS is unequivocally due to infection, that is the definition of sepsis. If sepsis progresses and leads to at least one organ failing, it becomes severe sepsis. And if, despite giving plenty of intravenous fluids, the blood pressure stays persistently low and needs vasopressor drugs, that's septic shock, which carries a significantly higher risk of death.
Right. To really anchor this concept, think of sepsis not just as the infection itself, but as the fire alarms that not only rings really loudly, but also sets off sprinklers that completely flood the building, causing more damage than the initial small fire might have. It's the body's own protective mechanism, the immune system, going into this uncontrolled overdrive and accidentally harming itself and its organs in the process. SIRS is diagnosed if you have 2 or more criteria, like abnormal body temp, high or low, high heart rate 90, high respiratory rate 20, or abnormal white cell count. But remember, SIRS could be caused by non-infectious things too. It's the infection part that makes it sepsis.
Identifying the infectious cause and its likely source is absolutely critical for guiding that initial empirical treatment in sepsis. While pretty much any pathogen could potentially cause sepsis, some are definitely more common than others, and their prevalence varies depending on the site of the initial infection. For respiratory sources, common culprits include Streptococcus pneumoniae, pneumococcus, Haemophilus influenza, and Staphylococcus aureus. If the sepsis starts in the urinary tract, you'll often find gram-negative bacteria like E. coli, Klebsiella, or Pseudomonas aeruginosa.
For skin and soft tissue infections leading to sepsis, Streptococcus pyogenes and Staphylococcus aureus are the usual suspects. In particularly vulnerable patients may be immunocompromised, or those with indwelling medical devices like catheters. The range of possible pathogens broadens. Could be S. aureus, Con S, Staphylococcus epidermidis, E. coli, Pseudomonas, even fungi like Candida. What's fascinating and often challenging is that in about 30% of sepsis cases, no specific organism is ever identified, even with good cultures. And rarely, sepsis can be caused by fungi, candida, viruses, or parasites. Recognizing these potential sources helps you narrow down your empirical antibiotic choices quickly, which is crucial for patient outcomes.
Okay, let's really dive into the pathophysiology, the cascade of chaos that underlies sepsis. When an infection triggers the immune system, it activates receptors, uses pathogen-associated molecular patterns, PMP, from the microbes, and damage-associated molecular patterns, DMPs, released from our own damaged cells. This complex activation sets off an uncontrolled, exaggerated inflammatory response, and it also activates the coagulation cascade. This is where the hemodynamic disturbances, the core clinical features of shock, really begin.
One of the earliest and most profound changes you see is widespread vasodilation. That's the widening of blood vessels all over the body. This significantly drops the systemic vascular resistance, SVR, causing a big fall in blood pressure. Clinically, this often presents as warm shock. The patient's hands and feet might feel warm, capillary refill might look normal, because blood flow to the skin is still okay, but critically, their vital organs might not be getting enough blood flow, leading to organ dysfunction.
Yeah, and happening at the same time as vasodilation is this phenomenon called capillary leak. The pro-inflammatory cytokines released during this out-of-control immune response directly damage the vascular endothelium, the inner lining of blood vessels. This damage makes the capillaries leaky. Fluid starts to extravasate, leak out from the blood vessels into the surrounding tissues. This leads to intravascular hypovolemia, a drop in the circulating blood volume, which further compromises blood pressure and tissue perfusion.
This is where our metaphor really helps understand it. Imagine your body's circulatory system is like a complex network of garden hoses. In sepsis, vasodilation is like all those hoses suddenly widening to their max capacity. Drops the water pressure, your blood pressure dangerously low. The capillary leak is like these hoses simultaneously developing countless tiny holes. So water, your vital blood plasma, seeps out of the system, further reducing the overall volume. Initially, your heart tries to compensate by pumping faster, tachycardia, and harder, but eventually it's just trying to push less and less water through leaky, wide-open hoses, a situation that's totally unsustainable for your organs.
Initially, the body does try to compensate. Mechanisms like increased heart rate, increased stroke volume. Plus, sympathetic drive increases systemic vascular resistance through hormones like adrenaline, cortisol, activating RATS and ADH. But as septic shock progresses, these compensatory mechanisms just get overwhelmed. Furthermore, myocardial dysfunction can develop. While early sepsis might show a hyperdynamic circulation where the heart's working really hard, later stages often see direct impairment of the heart's ability to contract, caused by circulating cytokines, hypoxia, acidosis. This further reduces cardiac output and makes the shock worse.
The ripple effect on organs is devastating. In the lungs, you get increased metabolic demand, combined with pulmonary edema from that capillary leak. Often leads to rapid breathing, tachypnoea, and can progress to acute respiratory distress syndrome, ARDS, causing severe hypoxia. Tissues throughout the body suffer from ischemia, lack of blood flow, and hypoxia, lack of oxygen. This forces them into inefficient anaerobic respiration, which produces lactic acid, leading to lactic acidosis. This results in widespread cellular dysfunction, damage, and ultimately necrosis, cell death.
The kidneys are also incredibly vulnerable. Reduced intravascular volume plus low blood pressure severely cuts down renal blood flow. This leads to acute renal failure. The brain, needing a constant supply of oxygen, glucose, and stable pH, shows signs of dysfunction. Confusion, altered consciousness, lethargy, irritability. This altered mental status is a really crucial indicator of severity and progression, often assessed using tools like ACBPU or the Glasgow Coma Scale, GCS.
And finally, the coagulation system just goes into chaos. Lipopolysaccharide, LPS, from gram-negative bacteria, along with potent cytokines like TNF-E, directly damage the vascular endothelium. This triggers widespread inappropriate activation of the coagulation cascade, leading to formation of microvascular clots all over the body, a dangerous condition called disseminated intravascular coagulation, DIC. Paradoxically, this widespread clotting uses up all the body's clotting factors, leading to simultaneous severe bleeding and thrombosis. Clinically, DIC can show up as purpura, that non-blanching purple rash. Signals a really dire prognosis.
Spotting the red flags of sepsis is absolutely paramount. Early recognition can save lives. The symptoms can sometimes be subtle, though, making it a tricky diagnosis. Patients might have a fever, but critically, hypothermia or even a normal temperature is possible, especially in the elderly, immunocompromised, or infants. Other common symptoms: shivers, headaches, muscle aches, and that subtle but crucial phrase, feels generally unwell. Often reported by family who notice a significant change. Rapid breathing, loss of appetite are also common.
On examination, the signs can be varied. You might see flushed skin initially, then warm or cold peripheries. Critically, check the capillary refill time, CRT, how long it takes for blood to return after pressure. Vital. A prolonged CRT, more than 2 seconds, indicates poor perfusion. Other worrying signs include skin mottling, looking pale, a non-blanching rash, petechiae or purpura, an altered level of consciousness, and reduced urine output. Any of these should immediately make you suspect sepsis.
It's also crucial to identify vulnerable patients, those at higher risk of developing severe sepsis. These include people who are immunocompromised due to chemo, steroids, HIV, very young babies and children, the elderly, pregnant women, postoperative patients, those with pre-existing diseases like diabetes or sickle cell, anyone with a history of sepsis, those with indwelling lines or catheters, IV drug users. A high index of suspicion in these groups is non-negotiable.
When you suspect sepsis, investigations are time-sensitive, really critical. Immediate tests include an arterial blood gas to check glucose, pH, PCO2, and crucially lactate, a marker of tissue hypoxia. You must also get blood cultures and other relevant cultures, urine, CSF, sputum swabs, before giving antibiotics. Further investigations include a full blood count, white cells, neutrophils, platelets, clotting tests, C-reactive protein, CRP for inflammation, urea and electrolytes, UNE, liver function tests, LFTs, to check organ function, and maybe imaging like a chest x-ray or ultrasound if needed to find the source.
To help recognize and stratify sepsis risk quickly, we use scoring systems. The National Early Warning Score 2, new WS2, is widely used in hospitals. A score of 7 or more means high risk, triggers immediate urgent review. Even a single parameter scoring 3 points demands high priority review. Beyond the score, always consider things like a non-blanching rash, mottled or ashen skin, or central cyanosis. In non-ICU settings, the QSOFA, Quick SOFA score, is a rapid triage tool. Score of 2 or more based on low blood pressure, systolic 100, high respiratory rate, or altered mentation, GCS 014, suggests higher risk of poor outcomes, prompts further investigation for sepsis. The key takeaway for you is, think sepsis. Early recognition is everything.
Okay, now for the most critical part. Management, the Sepsis 6 bundle, your urgent action plan. When sepsis is suspected, there can be absolutely zero delay. This bundle outlines 6 immediate life-saving steps you have to take.
First, oxygen. Give high-flow oxygen. Aim to keep arterial oxygen saturations above 94%. Hypoxia just makes organ dysfunction worse in sepsis. Second, blood cultures. This is vital. Take blood cultures and other relevant cultures before giving antibiotics. This helps identify the specific bug later and guides targeted therapy. But crucially, do not delay antibiotics waiting for cultures. Get them started.
Third, broad-spectrum antibiotics. Give full-dose intravenous bactericidal broad-spectrum antibiotics empirically, meaning based on your best guess of the likely pathogen and source, without waiting for culture results. Always ask about allergies first. Common choices might be piperacillin tazobactam for broad coverage, or vancomycin if you suspect MRSA or for penicillin allergies. For suspected meningococcal disease, benzylpenicillin is a rapid first choice. This initial empiric choice is often life-saving.
Fourth, IV fluid resuscitation. Give intravenous fluid boluses of 0.9% saline. Usually start with 500 milliliters or a weight-based dose. Rapidly reassess the patient's response, look at their blood pressure, urine output, and repeat fluid boluses as needed, guided by clinical judgment. Fifth, lactate measurement. Measure serum lactate levels. Persistently high lactate is a crucial marker of tissue hypoxia and ongoing poor tissue perfusion, even if the blood pressure seems okay for a moment.
And sixth, urine output monitoring. Put in a urinary catheter and monitor hourly urine output. This is a direct, immediate indicator of kidney perfusion and overall fluid status. In addition to these sepsis 6 steps, other crucial supportive care includes protecting the airway, maybe ventilation if needed, giving inotropes or vasopressors if blood pressure stays low, neurological monitoring, careful glucose management, hypo and hyperglycemia happen, pain management, clear communication with the family, and notifying public health if it's a notifiable disease. The sepsis 6 is your immediate life-saving protocol, designed to be done within that golden hour of diagnosis.
Sepsis, even when treated successfully, can cast a very long shadow. The complications are profound, often long-lasting. These include death, obviously, but also severe multi-organ failure affecting lungs, heart, kidneys, liver. Potentially permanent damage. Patients might lose limbs due to severe circulatory problems, suffer malnutrition, prolonged immunosuppression, which can lead to reactivation of dormant infections or getting new hospital-acquired infections. Neurological problems are common concentration difficulties, memory issues, higher risk of PTSD. Chronic pain and fatigue are also frequently reported by sepsis survivors.
Yeah, so prevention is just as crucial as treatment. This includes universal things like vaccination flu, pneumococcal vaccines, meticulous hygiene practices, strict adherence to aseptic technique in all medical procedures to prevent healthcare-associated infections. Clinicians have to maintain a high index of suspicion for sepsis, especially in those at-risk groups. Ensure early recognition and intervention. Furthermore, antibiotic stewardship, that judicious, appropriate use of antibiotics, plays a critical role. It helps prevent the emergence of resistant bugs, which are a major driver of severe sepsis. Your role in preventing sepsis starts on day 1 of your medical training. Seriously.
Okay, let's shift gears a bit to part 4. Unseen weapons, the world of toxins. Bacteria and some other microbes possess this potent form of chemical warfare. Toxogenesis is simply the ability of these microorganisms to produce toxins. We categorize these toxins into 2 major classes, exotoxins and endotoxins. And understanding the difference is key to understanding their impact.
Right. Exotoxins are soluble proteins that are actively secreted by bacteria. They're often highly specific in what they do and can act at sites far away from where the bacteria are actually growing. They work by directly destroying host cells or messing up their normal metabolic processes. Endotoxins, on the other hand, are cell-associated substances, specifically lipopolysaccharide, LPS, which is a structural part of the outer membrane of all gram-negative bacteria.
Yeah, and to illustrate that difference with a powerful metaphor, if a bacterium is a tiny invader in your body, exotoxins are like its specialized chemical weapons. Think precision-engineered, targeted missiles designed to cause very specific damage far and wide, even from a distance. Endotoxins are more like the debris or shrapnel from a destroyed enemy. Not intentionally harmful in the same targeted way, but the sheer quantity of this debris, especially from a massive gram-negative bacterial invasion, can trigger a devastating and overwhelming immune overreaction from your body.
That exaggerated response from endotoxins is exactly why they are a major pyrogen, a fever inducer, and a prime trigger for that severe inflammatory response leading to sepsis and septic shock, particularly from gram-negative bacteria like Pseudomonas or E. coli. The mechanism is quite elegant, actually. LPS, the endotoxin, activates specific immune receptors, mainly TLR4, toll-like receptor 4, found on macrophages and endothelial cells.
This activation stimulates a massive, uncontrolled release of powerful pro-inflammatory cytokines, things like interleukin-1, IL-1, IL-6, IL-8, and tumor necrosis factor alpha, TNFC, plus nitric oxide. This cytokine storm leads directly to the clinical features of sepsis, fever, severe low blood pressure for vasodilation, and widespread tissue injury. Endotoxin also activates the complement cascade, further fueling inflammation. And critically, it activates the coagulation cascade, leading to that dangerous, disseminated intravascular coagulation, DIC, we talked about earlier.
A classic and devastating example of endotoxin's impact is meningococcal disease, caused by Neisseria meningititis, a gram-negative diplococcus. The rapid release of its endotoxin directly triggers this overwhelming inflammatory response, leading to small vessel thrombosis and widespread skin necrosis, presenting as that characteristic petechial or purpuric rash. This infection can progress incredibly rapidly to septic shock and multi-organ failure, demands immediate recognition and treatment.
Okay, now let's turn to exotoxins. As we said, secreted proteins designed for more targeted destruction. They can be broadly categorized by how they work. Type I exotoxins, often called superantigens, bind to cell surface receptors and hyperstimulate intracellular signaling pathways, prime example. The superantigens made by S. aureus or S. pyogenes. They nonspecifically bind MHC class II molecules and T-cell receptors, causing that massive, uncontrolled cytokine release leading directly to toxic shock syndrome.
Type 2 exotoxins are membrane-damaging toxins. They either form pores directly in the host cell membranes, messing up their integrity, or they're enzymes that act on membrane lipids. An example is pneumolysin from Streptococcus pneumonia. This toxin causes direct cytotoxicity, kills lung epithelial cells, contributing significantly to the severe tissue damage you see in bacterial pneumonia.
Let's delve into a few notorious exotoxin producers. First, Clostridium botulinum and the disease it causes, botulism. This is a gram-positive, rod-shaped, strictly anaerobic, spore-forming soil bacterium. Botulism is rare, but potentially fatal, caused by the most potent biological toxins known, the botulinum neurotoxins, BO and T.
Botulism can happen in several forms. Foodborne botulism from eating preformed toxin and improperly canned foods. Infant botulism from intestinal infection, often linked to eating honey. And wound botulism from spores getting into a wound, sometimes seen with IV drug use. The symptoms: weakness, blurred vision, fatigue, and a characteristic progressive descending flaccid paralysis, meaning it starts in the face and moves down, affecting facial, then respiratory muscles. Can lead to life-threatening respiratory failure. Patients also get autonomic effects like dry mouth and postural hypotension.
The mechanism of action for botulinum neurotoxin is fascinating and clinically really significant. BO&T specifically blocks the release of acetylcholine, the main excitatory neurotransmitter, at the peripheral alpha motor neurons. This blockade stops muscle contraction, causing that characteristic flaccid paralysis, the profound clinical relevance. This same toxin, in highly purified tiny doses, is used therapeutically as Botox, for cosmetic treatments to relax wrinkles, and for medical conditions like chronic migraines, muscle spasms, excessive sweating. Diagnosis often involves finding the toxin in samples. Treatment includes a botulinum antitoxin for passive immunity, plus crucial supportive care, especially mechanical ventilation if breathing is affected.
Next, we have Clostridium tetani and the disease tetanus, another common soil bacterium. Also gram-positive, rod-shaped, spore-forming, motile, strictly anaerobic. Tetanus infection happens when spores get into deep, low-oxygen wounds, allows them to germinate and produce toxin. The symptoms are dramatically different from botulism. Patients get stiffness in the jaw, famous lockjaw or trismus, followed by painful involuntary muscle spasms. Can manifest as rhizus sardonicus, that sardonic grin, or epistatos, severe arching of the back from powerful spasms. Patients also suffer high temperature, sweating, high heart rate.
The mechanism for tetanospasmin, the tetanus toxin, is the opposite of botulinum toxin. Tetanospasmin travels from the wound to the central nervous system, binds to the presynaptic membrane of inhibitory motor neurons. There, it interferes with the release of inhibitory neurotransmitters, mainly GABA and glycine. This leads to unopposed excitation of motor neurons, resulting in continuous muscle contraction and those severe spastic paralysis spasms seen in tetanus. Diagnosis is mainly clinical, based on symptoms. Treatment involves tetanus antitoxin to neutralize unbound toxin, muscle relaxants to manage spasms, and intensive supportive care. Prevention through routine vaccination is highly effective.
Let's consider Vibrio cholerae and cholera. This is a gram-negative bacterium. Causes severe infection of the small intestine due to its potent cholera toxin and enterotoxin. The mechanism of cholera toxin is quite specific. It leads to continuous activity of adenylyl cyclase in the intestinal epithelial cells. This results in a massive secretion of water and salts into the gut lumen, completely overwhelming the colon's ability to absorb it.
The clinical consequence is a devastating secretory diarrheal illness, characterized by profuse watery diarrhea, often described as rice water stools, that can rapidly lead to severe dehydration, electrolyte imbalances, and hypovolemic shock if not treated quickly. Cholera spreads mainly through unsafe water or food contaminated with human feces, highlights the critical importance of sanitation and clean water infrastructure in preventing outbreaks.
Other significant exotoxins to know about: M protein from Streptococcus pyogenes. Acts as a superantigen, but also has strong antiphogocytic properties, helps tissue invasion. Another important one is alpha toxin from Clostridium perfringens, an anaerobic bacterium often associated with gas gangrene. This toxin causes excessive platelet aggregation, blocking small blood vessels, leading to tissue anoxia and necrosis.
This brings us nicely to necrotizing fasciitis, a severe, rapidly progressive bacterial infection of the skin, subcutaneous tissue, and the fascia, the connective tissue surrounding muscles, often dramatically called a flesh-eating disease, can be caused by various bacteria, including S. aureus, S. pyogenes. group A strep, but also polymicrobial infections involving gram-negatives and anaerobes like Clostridium perfringens. This infection carries an extremely high mortality rate, maybe 10–40%, but climbing up to 70% if septic shock develops.
Symptoms include fever, swelling, and extreme pain, often way out of proportion to how the injury looks initially, followed by red or purple skin discoloration due to thrombosis, clotting of the small vessels. Critically, sensation might actually be reduced in the affected area as nerves are destroyed. Can happen anywhere in the body, but common in extremities and genitals, where it's called Fournier's gangrene. Risk factors include immunosuppression, diabetes, alcoholism, trauma, surgery, IV drug use. This is a true surgical emergency. Needs immediate debridement and aggressive broad-spectrum antibiotics.
Okay, let's move to part 5. The inner ecosystem and uninvited guests, microbiota and biofilms. Our microbiota is this incredibly complex, dynamic community of microorganisms. Includes bacteria, bacteriophages, viruses, archaea, fungi, protozoa, that inhabit a particular environment, most notably our human body, the gut, skin, oral cavity.
Right, and this is where our metaphor comes in. Your microbiota are like a bustling, vibrant city inside you. Most residents are helpful citizens, the commensals, performing vital public services like helping digest food, making vitamins, defending against unwelcome visitors. But when the city's delicate balance gets disrupted, opportunistic troublemakers, the pathogens, can take over and cause problems. Your gut microbiota, for instance, is dominated by phyla like firmicutes and bacteroidetes, but also includes actinobacteria and proteobacteria. They do essential things: break down complex carbs we can't digest ourselves, produce short-chain fatty acids, SCFAs like butyrate, which regulate the immune system, promote gut barrier integrity, even synthesize crucial vitamins. They play a critical role in shaping our immune system development from birth. ###A. Acquiring our microbial companions.
We get these microbial companions through both vertical and horizontal transmission. Vertical transmission happens directly from parents. For example, exposure to the mother's vaginal and gut bacteria during natural childbirth is a main seeding event, establishes the foundational microbiome for a newborn.
And a crucial clinical example of vertical transmission is Group B Streptococcus, GBS, or Streptococcus agalactiae. This bacterium is found in the reproductive tracts of up to 35% of healthy women, often without causing any symptoms to the mother. However, it can be transmitted to newborns during birth, can lead to severe neonatal infections like sepsis, meningitis, pneumonia, which can be devastating. This is why pregnant women are typically screened for GBS colonization. And if positive, they get intravenous antibiotics during labor to significantly reduce the risk of transmission to the baby.
Horizontal transmission, on the other hand, happens from the environment or from non-parental individuals. Diet is a major factor shaping the gut microbiota throughout life. Different foods support different microbial populations. Other sources include direct contact with family members, pets, environmental exposures.
But what happens when that delicate balance in our microbial city is lost? This state is called dysbiosis, an imbalance or disruption in the microbial community. Antibiotics are a major culprit here. While life-saving, they profoundly alter the population structure of the microbiome, a bit like dropping a bomb on the city. While the overall structure might eventually recover somewhat, the specific genomic makeup is often not fully equivalent, which can inadvertently open the door for opportunistic pathogens to thrive in the chaos.
Exactly. This is why long-term antibiotic use can lead to overgrowth of Candida albicans, causing thrush or vaginal yeast infections. And critically, the multiplication of Clostridioides difficile, CDI. CDI causes severe colitis when the normal gut microbiome is disrupted, usually by antibiotics. To restore balance, we sometimes use symbiotic interventions. Probiotics are live microorganisms, usually bacteria or yeasts, that when consumed in adequate amounts provide a health benefit. Prebiotics are non-digestible food components that selectively stimulate the growth or activity of beneficial microbes already in the gut. Food for the good guys. Symbiotics are products that combine both probiotics and prebiotics.
And for severe, recurrent Clostridioides difficile infection that doesn't respond to standard antibiotics.
Yeah.
A remarkable intervention is fecal microbiota transplantation, FMT. This involves transferring stool from a healthy donor to the patient, effectively repopulating their gut with a diverse, healthy microbiome, kicking out the bad guys. FMT has a really high success rate, around 90% for recurrent CDI, underscores the profound impact of our microbiota on health.
Finally, let's talk about biofilms. Think of these as microbial fortresses. A biofilm is a complex microbial community, often multiple species together. Enclosed within this extracellular matrix of polymeric substances, polysaccharides, proteins, DNA, like a sticky glue. These biofilms form on various surfaces: human tissues, medical devices, inanimate objects.
Yeah, this is a powerful clinical concept. Biofilms are like microscopic cities building fortresses against attack. That extracellular matrix is their protective wall. Makes them incredibly difficult for antibiotics or attacking army to penetrate and wipe them out. This is exactly why infections associated with medical devices are so persistent and challenging to treat. This environment also allows for genetic exchange between bacteria, helping spread antimicrobial resistance. The NIH estimates that over 80% of microbial infections are actually related to biofilms. It's huge.
Clinically, you'll run into biofilms in many places. Dental plaques are a classic example, persistent infections in patients with cystic fibrosis lungs. And critically, biofilms are a major problem on medical implants and indwelling devices, like vascular catheters, prosthetic valves, artificial joints, where coagulase-negative Staphylococci, con S, like S. epidermidis, are notorious for forming these resistant microbial strongholds, leading to chronic, often difficult-to-resolve infections.
All right, let's embark on part 6 now. From head to toe, a tour of systemic infections. We'll start our journey with the respiratory tract infections, where our body has its crucial first line of defense. The respiratory tract is divided into the upper respiratory tract, URT, that's the nasal cavity, pharynx, larynx, functions mainly to filter, heat, humidify the air we breathe. Below that is the lower respiratory tract, LRT, trachea, bronchi, lungs, where the vital gas exchange happens.
The respiratory tract has some remarkable natural defenses. In the URT, you've got nasal hairs, turbulent airflow trapping particles. Throughout the tract, mucus traps pathogens. And the mucociliary escalator, ciliated epithelial cells, constantly sweeps mucus and trapped stuff upwards for expulsion, coughing it out. We also have antimicrobial peptides, a sophisticated mucosal immune system. While the URT has abundant normal flora, the LRT was traditionally thought sterile. Now we know it has low levels of microorganisms too. #UIV, infections of the respiratory tract.
Let's consider some key URT infections: sinusitis or rhinosinusitis, inflammation of the paranasal sinuses, almost always with inflammation of the nasal cavity too, the vast majority of cases. Viral, often follows a common cold. But a bacterial minority can be caused by bugs like Streptococcus pyogenes or Haemophilus influenza. This inflammation and mucus buildup blocks sinus drainage, leading to the symptoms.
Clinically, sinusitis presents with common prelude symptoms, congestion, discharge, but also often purulent, thick nasal discharge and facial pain or tenderness that gets worse when you lean forward. A key clinical clue for bacterial sinusitis is often called double sickening, where a patient starts getting better from a viral cold but then suddenly worsens after about 5-7 days. Most viral cases clear up within 10 days without anything specific, but antibiotics are considered for prolonged, severe cases or in immunocompromised patients.
A critical, potentially life-threatening URT infection, especially in kids, is epiglottitis. This is acute inflammation of the epiglottis and the surrounding structures above the vocal cords. It can rapidly lead to edema, swelling, and life-threatening airway narrowing. Historically, most common cause was Haemophilus influenza type B, Hive in children. But thanks to widespread Hive vaccination, it's now more often caused by Streptococcus pneumonia, other bacteria, or viruses.
The clinical relevance here is huge. Airway compromise is common and happens fast, especially in kids where the airway is smaller. Your absolute top priority: secure the airway. Often needs urgent laryngoscopy and intubation. Patients classically present with Sutter high fever, sore throat, drooling, leaning forward, the tripod position, often with inspiratory stridor, a high-pitched breathing sound. A lateral neck x-ray might show that distinctive thumbprint sign from the swollen epiglottis.
Moving down to the LRT, pneumonia is a major global threat. Significant cause of illness and death worldwide, defined as inflammation of the lung parenchyma, the alveoli and bronchioles, can be classified pathologically. Lobar, affecting a whole lobe, bronchial pneumonia, patchy consolidation around bronchioles, or interstitial, affecting tissue between alveoli.
Epidemiology shows pneumonia carries significant morbidity and mortality, especially in vulnerable groups. Risk factors: increasing age, comorbidities like heart failure or COPD, recent viral URT infections, impaired airway protection, maybe from neurological issues, smoking, various environmental factors. Causes are diverse. Bacteria are most common. Viruses like influenza, COVID-19, fungi, Pneumocystis jirovecii is important in immunocompromised. Even parasites.
Clinically, pneumonia typically presents with a cough, often producing sputum, can be purulent or blood-tinged, fever, chloritic chest pain, sharp pain, worse with breathing. On examination, decreased breath sounds or crackles, rales, and auscultation. We commonly classify pneumonia based on where it's acquired. Community-acquired pneumonia, CAP, got it outside hospital. Or hospital-acquired pneumonia, HAP, develops 48 hours or more after hospital admission. HAP is further split into early onset, often S. pneumonia, and late onset, Yochium RSA Pseudomonas. Late onset often needs different, broader antibiotics due to resistant bugs.
Bacterial causes of pneumonia are often split into typical and atypical. Typical bacteria are usually visible on gram stain, sensitive to beta-lactam antibiotics. Most common cause of CAP is Streptococcus pneumonia, gram-positive coccus, though less common now with vaccination. Other typicals include Staphylococcus aureus, Haemophilus influenza. Atypical bacteria, on the other hand, generally resistant to beta-lactams, not easily gram-stained or cultured by standard methods. Key examples: Legionella pneumophilia, Mycoplasma pneumonia, Chlamydia pneumonia. These often cause a slower onset, maybe a non-productive cough.
To guide management decisions and predict mortality risk in CAP, you'll use the C or B65 score. Gives 1 point for each. Confusion, urea 7 mmol/L, respiratory rate often 30, blood pressure, systolic 90 or diastolic E60, and AJU 65. Score 0-1. Usually managed at home. 2 points. Needs hospital admission. 3 or more. Usually needs assessment for ICU admission. Management involves prompt antibiotics, often penicillin, maybe atomacrolide for atypicals. Supportive care, 4V antibiotics for severe cases, maybe ventilation. Smoking cessation, appropriate vaccinations, flu, pneumococcal, are crucial for prevention.
Let's focus on one specific, really significant LRT pathogen, tuberculosis, TB, caused by Mycobacterium tuberculosis. This is a slow-growing, gram-positive bacterium, but its distinctive feature is its unique cell wall. High concentration of mycolic acid makes it resistant to decolorization by acid alcohol, so we identify it as an acid-fast bacillus using the Seal-Nielsen stain. TB is a classic re-emerging infectious disease, still a huge global problem.
Clinically, TB typically presents with a chronic cough, more than 2 weeks, sometimes producing blood-tinged sputum, hemoptysis. Systemic symptoms are prominent: unexplained weight loss, night sweats, persistent fever. Transmission: inhalation of aerosolized droplets from an infected person, highly contagious in crowded or poorly ventilated places. Risk factors: close exposure to active TB, born in or travel to endemic countries, HIV infection, immunosuppressive meds. Management is complex. Needs multi-drug antibiotic therapy, usually rifampicin, isoniazid, pyrazinamide, ethambutol, RIPE, for prolonged periods, 6-9 months, to ensure eradication and prevent resistance. The BCG vaccine is used for prevention in high-risk individuals.
We should also briefly mention 2 other critical viral causes of LRT infections: influenza, caused by the orthomyxovirus; enveloped negative sense single-stranded RNA virus, causes URT and LRT infections, usually with more severe systemic symptoms, fever, muscle aches, fatigue, than a common cold. COVID-19, caused by SARS-CoV-2, enveloped positive sense ssRNA coronavirus, binds to the ACE2 receptor, led to the global pandemic, causes a wide spectrum of URT and LRT infections. Potential complications include ARDS, thrombosis, cardiovascular issues, and often long COVID.
Okay, let's move down to explore the gastrointestinal tract infections, the body's inner tube. Gastroenteritis is a common syndrome. Nausea, vomiting, diarrhea, abdominal pain, caused by viruses, bacteria, parasites. Food poisoning refers to infective or toxic disease from contaminated food water. If it's due to performed toxins, food intoxication, the incubation period is usually really short, maybe 1 to 6 hours. Vomiting often prominent. Traveler's diarrhea is super common, affects 30-70% of travelers. Mostly bacterial, 80 to 90%, with E. coli, specifically E-tech enterotoxigenic E. coli, being the most common culprit.
For bacterial causes, while many contribute, we need to focus on a few with critical clinical implications. You'll encounter Shiga toxin-producing E. coli, STEC, also known as endohemorrhagic E. coli, EAT. Serotype 0157H7 is the most well-known. This strain causes watery diarrhea that often progresses to grossly bloody diarrhea, hemorrhagic colitis, plus severe abdominal cramps. A life-threatening complication in 10–15% of cases, especially kids and elderly, is hemolytic uremic syndrome, HUS. Involves acute kidney injury, hemolytic anemia, low platelets.
And this is a critical clinical anchor for you.
Yeah.
For celiac infections, antibiotics are contraindicated. Absolutely not. Giving antibiotics to a patient with STEC significantly increases the risk of developing HUS, believed to promote release of more Shiga toxin. Diagnosis is via stool culture for Shiga toxin in specific serotypes. Management: purely supportive care, mainly hydration.
Another extremely important GI infection, particularly in hospitalized patients or after antibiotics, is Clostridioides difficile infection, CDI, caused by an anaerobic gram-positive rod that makes highly resistant spores. enables fecal-oral transmission, hard to kill on surfaces. C. difficile produces potent toxins, toxin A and toxin B. It commonly colonizes the GI tract asymptomatically, but causes severe colitis when the normal gut microbiome is disrupted, most often by broad-spectrum antibiotics killing off competitors. Leads to symptoms from mild diarrhea to severe, life-threatening pseudomembranous colitis and toxic megacolon.
Investigations for CDI. Stool test for C. difficile and its toxins. Imaging if complications suspected. Management involves specific antibiotics like oral vancomycin or fidaxomicin, but critically requires stringent infection control measures. Isolate patients in side rooms, use appropriate PPE, and most importantly, hand washing with soap and water is essential. Alcohol hand gels are ineffective against C. difficile spores. Must use soap and water. Antimicrobial stewardship, minimizing unnecessary antibiotic use, is the primary way to prevent CDI.
Finally, let's briefly touch on typhoid fever, caused by Salmonella typhi. This is a systemic infection acquired through contaminated food or water. Bacteria invade the small intestine, then spread via bloodstream to liver, spleen, bone marrow. Presence and stages. Stage 1 fever, malaise, headache. Stage 2 high fever, abdominal distension, characteristic rose spots on skin, maybe delirium. Stage 3 potential complications like intestinal bleeding or perforation. Crucially, 3-5% of infected people become asymptomatic carriers, often harboring bacteria in their gallbladder, shedding them in feces, posing a risk for further spread.
Just a quick taste of parasitic GI infections. Protozoal causes like Giardia, Cryptosporidium, common and immunocompromised, and Amoeba histolytica can cause bloody diarrhea. Tend to have longer incubation periods, often over a week. For helminth infections, Enterobius formicularis threadworms or pinworms is the most common helminth infection in Western Europe, USA. Female worm goes to anus at night to lay eggs, causes intense itching. Diagnosed via the tape test, treat all household members with anti-helminth meds, plus strict hygiene. General management for GI infections. Always prioritize hydration. Specific antimicrobials only when indicated. Public health notification if needed.
Okay, let's turn our attention now to genital tract infections and HIV, the hidden battlegrounds. The urogenital tract has unique anatomy and microbiota. Kidneys, bladder, normally sterile, but the distal third of the female urethra and the vagina have normal microbiota, mainly lactobacilli. Help maintain low pH, protect against pathogens. The cervix acts as a barrier, maintains sterility of the upper female reproductive tract.
The most common sexually transmitted infections, STIs, you'll encounter, include chlamydia, making up about 46% of new diagnoses, gonorrhea, around 20%, genital herpes, genital warts, and syphilis, which is a re-emerging concern, especially among gay, bisexual, and other men who have sex with men, GBMSO. These infections often carry significant stigma. Clinicians have to be prepared to offer patient-centered, non-judgmental care, encourage early presentation and treatment.
Let's deep dive into a couple of key STIs. Chlamydia, caused by Chlamydia trichomatis, an obligate intracellular gram-negative bacterium, notoriously asymptomatic. Maybe 70% of women, 50% of men show no symptoms, can infect urethra, cervix, rectum, conjunctiva, even nasopharynx if symptomatic. Dysuria, painful urination, discharge, abnormal bleeding in women. Major clinical concern is its potential to lead to pelvic inflammatory disease, PID, in women if untreated. Can cause chronic pelvic pain, infertility, ectopic pregnancy.
Syphilis, caused by the spirochete treponema pallidum, another critical STI, unfortunately re-emerging, progresses through distinct stages. Primary syphilis presents with a chancre, a painless ulcer, usually at the infection site. Secondary syphilis involves a widespread rash, lymphadenopathy, moist lesions called condylomata lata, latent stage, asymptomatic, but infection persists. And finally, tertiary syphilis can develop years later, severe cardiac, neurologic, neurosyphilis, skin manifestations, gummas. Neurosyphilis, for instance, can cause personality changes, headaches, seizures. Early diagnosis and treatment, usually with penicillin, are crucial to prevent progression, reduce transmission.
All right, let's tackle HIV. A global pandemic and immune sabotage. Understanding HIV is fundamental to modern medicine. HIV, human immunodeficiency virus, is the virus. Specifically attacks and destroys CD4 plus T cells, critical immune cells, leads to severe immune deficiency. AIDS, acquired immunodeficiency syndrome, is the most advanced stage of untreated HIV infection. Diagnosed when CD4 count drops below a critical level, usually 200 cells, and or specific opportunistic infections or cancers appear AIDS-defining illnesses.
To really grasp the impact of HIV, Think of like a saboteur infiltrating your body's immune command center, the CD4 cells, systematically destroying its communication network, dismantling its ability to coordinate a defense. AIDS is when that command center is so crippled the entire defensive system collapses, leaves the body utterly vulnerable to any opportunistic attack, common infections, rare cancers which a healthy immune system would easily handle.
The virus itself is a retrovirus. Retroviridae family. Mainly HIV-1, global pandemic, and HIV-2. Mostly West Africa, slower progression. It's enveloped. Surface glycoproteins like GP120 and GP41 are crucial for attaching to and entering host cells, binds to CD4 receptors and co-receptors on immune cells. Inside its capsid, made of P24 protein, it has two single-stranded RNA strands and key enzymes, reverse transcriptase, integrase, protease, all targets for antiretroviral drugs.
HIV transmission happens through specific bodily fluids with enough viral load. Blood, semen, preseminal fluid, rectal fluids, vaginal fluids, breast milk. Primary routes. Unprotected sexual intercourse, anal sex, highest risk, sharing needless syringes, IV drug use, historically contaminated blood products, organ transplants, rare now with screening. Vertical transmission parent to child during pregnancy, childbirth, breastfeeding also a major route. But interventions can reduce this risk from 30% down to 1%.
A truly paradigm-shifting concept in HIV care is undetectable, untransmittable. This means individuals living with HIV who are on effective antiretroviral therapy, RT, and achieve an undetectable viral load, meaning the virus level in their blood is too low for standard tests to find. They do not transmit the virus to sexual partners. This is a powerful message. Combat stigma, promotes health, also important. Saliva, sweat, tears, urine do not carry enough virus to transmit HIV.
The viral replication cycle is complex but targeted by RT. Several key steps. Binding, GP120 to CD4 co-receptor. Fusion, viral envelope fuses with cell membrane, or host transcription, viral RNA to proviral DNA via reverse transcriptase. Integration, proviral DNA inserted into host genome via integrase. Replication, host cell makes new viral RNA proteins. Assembly of new viral particles. And finally, budding, new virions exit the cell, ready to infect others.
The stages of infection typically progress. Primary HIV infection, seroconversion, 2-4 weeks post-exposure, often a flu-like illness, fever, rash, sore throat, malaise. Critically, people are highly infectious during this stage, followed by a long asymptomatic stage can last years. Gradual decline in CD4 cells, final stage. Advanced HIV infection or AIDS, CD4 count 200 cells and/or specific opportunistic infections or cancers appear.
Indicator conditions are conditions that should prompt HIV testing, regardless of known risk factors. AIDS-defining conditions, usually seen with CD4-200, include Kaposi sarcoma, pneumocystis jirovecii pneumonia, PCP, cerebral toxoplasmosis, esophageal candidiasis, PCP, caused by the fungus P. jirovecii, extremely rare in immunocompetent people, common with CD4-200, presents with shortness of breath, non-productive cough, Kaposi sarcoma, a tumor caused by human herpes virus type 8, HHV8, often seen in AIDS, painless purple skin lesions can affect internal organs.
HIV testing is paramount. Early diagnosis, early intervention, different types. RNA-D-Day tests find viral genetic material. Antibody tests find IgM against HIV. Antibody antigen tests find both antibodies plus P24 viral antigen. Fourth-generation tests detecting both P24 antigen and antibodies are most sensitive. Allow earlier detection. There's a window period time between exposure and accurate detection. 4 to 6 weeks for antibodies, sometimes up to 12 weeks. P24 antigen helps bridge this gap. Retesting crucial if recent exposure suspected. Offer testing if patient requests, has risk factors, lives in high prevalence area, presents with indicator conditions. Addressing barriers like access, fear, stigma is crucial.
HIV management centers on prevention and treatment. Prevention. Consistent condom use, regular testing, single-use syringes for IV drug users, pre-exposure prophylaxis, pre-PP, Archie for high-risk HIV-negative people, post-exposure prophylaxis, PP, RDS started within 72 hours after potential exposure, 28-day course. For those living with HIV, antiretroviral therapy, RART, is the cornerstone.
RT involves a combination of 3 or more drugs from different classes. NRTIs and NRTIs, PIs, EIs, EIs, suppresses viral replication to undetectable levels, effectively maintains immune function, prevents opportunistic infections, lets people live long, healthy lives. Lifelong therapy needs meticulous adherence. Monitoring CD4 count and viral load is crucial. Assess treatment efficacy, detect drug resistance, potential complications starting RT, especially with low CD4s, immune reconstitution inflammatory syndrome, IRS. Inflammatory response can unmask or worsen infections. The story of HIV/AIDS, from terrifying killer to manageable chronic condition, really highlights the impact of science, public health efforts, and compassion in fighting stigma.
Okay, let's talk about part 7 now. Viruses as architects of disease, adaptation, and cancer. Viruses are masters of survival, evolution. Their ability to adapt is a constant challenge for public health. Viral adaptation is the process where viruses change over time, responding to their environment, mainly through genetic changes, mutations, recombinations.
The consequences, profound, can lead to emergence of new strains with altered virulence, more harmful, or transmissibility, spread easier, posing greater threats. Understanding these adaptation mechanisms is absolutely crucial for developing effective control strategies, vaccines, antiviral drugs.
There are two main distinct mechanisms of adaptation that are clinically critical to get your head around: antigenic drift and antigenic shift. Antigenic drift is gradual, happens within a single virus strain. Involves small, continuous genetic changes, mostly point mutations, in viral genes coding for surface proteins, like hemagglutinin and HA and neuraminidase NA in influenza. These minor changes generate new genetic diversity, let the virus subtly alter its antigenic profile, evade pre-existing host immunity.
Antigenic shift, though, is sudden and dramatic. Involves a major change in the viral genome, typically through reassortment of genetic material between two or more different viral strains co-infecting the same host cell, results in a completely new viral subtype with a novel antigenic profile. The human population has little or no pre-existing immunity. A critical point for you. Antigenic shift occurs only in influenza A viruses. They have a segmented RNA genome that allows this reassortment.
Right. So to anchor these crucial concepts, think of antigenic drift like a virus subtly changing its disguise each year, just enough to slip past the security guards your immune system looking for last year's disguise. Continuous, low-level evolution. Antigenic shift, however, is like two different viruses completely swapping entire sections of their outfits, creating a brand new, unrecognizable threat overnight. Recognizing these ancient changes and the potential for these dramatic shifts is absolutely critical for public health vaccine development and pandemic preparedness.
Our classic case study for viral adaptation, influenza, a true master of this process. Clinically, influenza causes severe respiratory problems, typically seasonal outbreaks in winter. Transmitted directly via respiratory droplets, epidemics can sweep through populations every 2-3 years.
The virus itself, an orthomyxovirus,
Yeah.
developed single-stranded RNA genome segmented, high mutation rate, 3 main serotypes, A, B, C. Influenza A is most significant for pandemics, infects wide range of avian and mammalian hosts, including us. Its envelope has 2 key surface glycoproteins, hemagglutinin, HA, for attachment, neuraminidase, NA, for release, categorized into subtypes like H1N1, H2N2, H3N2 in humans, reflecting variations in agent antigens.
Pathogenesis of flu involves the virus multiplying preferentially in ciliated epithelial cells of the respiratory tract. Rapid replication causes functional structural abnormalities, cell shedding, interferes with mucociliary escalator, impairs clearance, increases susceptibility to secondary bacterial infections. Commonly S. pneumonia, H. influenza, S. aureus. Flu symptoms, fever, muscle aches, fatigue largely caused by the host's robust immune response.
Treatment for flu, primarily symptomatic. Rest, fluids, analgesics, cough suppressants, antivirals like oseltamivir or zanamivir are available, usually reserved for high-risk groups, elderly, immunocompromised, pregnant, or those with severe complications. Hospitalization often needed for severe cases or complications like viral pneumonia, most effective prevention, annual immunization with a multivalent vaccine, updated yearly to target circulating strains.
The pandemic potential of influenza A viruses is undeniable, responsible for sporadic global pandemics with significantly higher mortality than seasonal flu. Stark example, 1918 Spanish flu H1N1. Avian origin, estimated 50 million deaths worldwide. Other pandemics, 1957-1968. Principal reservoir for antigenic shift variants triggering these pandemics, pigs, horses, fowl species. Significance of viral adaptation cannot be overstated. Directly impacts virulence, transmissibility, treatment response, dictates constant need for new antiviral drugs, vaccine development.
Now for a truly surprising critical link, viruses and cancer. Might seem counterintuitive, but some viruses are architects of disease in a totally different way. Oncogenic viruses are viruses that can cause cancer by altering host cell genetic material, hijacking cellular machinery for their own ends. Cancer itself is fundamentally inappropriate, uncontrolled cell proliferation, normally tightly controlled by cell cycle machinery. Key player in this control, P53, a tumor suppressor protein, often called the guardian of the genome.
And here's why P53 is so vital and why viruses target it. P53 acts as a critical checkpoint. If DNA damage is detected in a cell, P53 arrests the cell cycle, gives the cell time to repair. If damage is too severe, irreparable, P53 induces apoptosis, programs cell death, prevents damaged cell replicating, potentially becoming cancerous. Works partly by activating P21, which inhibits CDKs that drive cell division. The metaphor for P53. Clear. Imagine P53 is the vigilant security guard at your cell's division factory, meticulously checks every cell for damage, halts production for repairs. If damage too severe, triggers factory self-destruction to protect the whole system. Oncogenic viruses, in their sinister efficiency, often disarm or kidnap this security guard, allowing damaged cells to proliferate unchecked.
There are several key oncogenic viruses and their associated cancers you absolutely need to know. Human papillomavirus, HPV, linked to cervical, anal, or pharyngeal cancers. Epstein-Barr virus, EBV, associated with Burkitt lymphoma, Hodgkin lymphoma, nasopharyngeal carcinoma, hepatitis B virus, HBV, and hepatitis C virus, HCV, major causes of hepatocellular carcinoma liver cancer, primarily through chronic infection, inflammation, cirrhosis.
Human T-cell lymphotropic virus type 1, HTLV1, causes adult T-cell leukemia lymphoma. Kaposi sarcoma-associated herpes virus, KSHV-HVHV8, cause of Kaposi sarcoma, especially with AIDS. Primary effusion lymphoma. And finally, Merkel cell polyomavirus, MCV, linked to Merkel cell carcinoma, rare but aggressive skin cancer.
Let's focus on HPV and cervical cancer in detail. This is a preventable cancer with a clear viral link. HPV is the most common STI globally. Estimated 80% of sexually active unvaccinated men and women get an HPV infection at some point. HPV types classified as low risk or high risk. Low risk types like HPV 6 and 11 cause benign genital warts. But high risk types, notably HPV 16, 18, 31, 33, 35, 39, are responsible for cervical intraepithelial neoplasia, CIN, and, if untreated, invasive cervical carcinoma. HPV 16 most common in squamous cell carcinoma, HPV 18 in adenocarcinoma.
The progression from untreated high-risk HPV infection to cervical cancer is a major public health concern. While most HPV infections clear spontaneously, persistent infection with high-risk types can lead to cellular abnormalities. Risk factors for cervical cancer: younger age at first intercourse, high lifetime number of sex partners, smoking, immunodeficiency, insidious nature of cervical cancer, often asymptomatic in early stages. When symptoms appear, irregular vaginal bleeding, foul-smelling discharge, pelvic pain often indicates more advanced disease.
The pathology of CIN, cervical intraepithelial neoplasia, is graded based on extended dysplasia, abnormal cell growth, seen on histology. CIN1, mild; CIN2, moderate; CIN3, severe dysplasia or carcinoma in situ. CIN3 is considered precancerous, unlikely to regress on its own, high potential to progress to invasive carcinoma if not treated.
The mechanism of oncogenesis by high-risk HPV, prime example of viral hijacking of cell control. When high-risk HPV infects cervical epithelial cells, its viral DNA can integrate into the host cell's DNA. Integration often disrupts the viral E2 gene, which normally regulates expression of viral oncogenes E6 and E7. Its disruption leads to uncontrolled overexpression of E6 and E7. E6 then binds to and degrades the crucial tumor suppressor protein P53. Simultaneously, E7 binds to and inactivates RB, retinoblastoma tumor suppressor protein, another key cell cycle regulator. Combined outcome of inactivating both P53 and RB, complete removal of critical cell cycle checkpoints, leads to uncontrolled cellular proliferation, eventually cancer.
Diagnosis of cervical cancer and precursors relies heavily on cervical screening. Pap smear detects early cellular abnormalities. Modern screening also incorporates HPV primary screening tests to detect high-risk HPV types. If abnormalities found, colposcopy gives magnified view of cervix, biopsies taken for histological grading. Treatment for precancerous lesions often involves procedures like loop electrosurgical excision procedure, AEEP, to remove abnormal cells.
However, the most effective, proactive strategy is prevention through vaccination. HPV vaccines target high-risk HPV types for age 16-18, causing most cervical cancers. Vaccination recommended for all children aged 12-13. Catch-up vaccination offered to girls under 25, increasingly boys and men too, especially GBMSM. Beyond cervical cancer, high-risk HPV also causes other cancers. 25-35% of oral cancers, 90% of anal cancers. HPV 16 most common genotype. Early detection through screening, maximizing vaccination rates are absolutely essential public health strategies. Significantly reduce global burden of these HPV-related cancers.
We've seen the players, their strategies. Now let's turn to part 8, the arsenal and the threat, antimicrobial agents, and resistance. This is where we look at how medicine fights back, and the looming challenge threatening our whole approach. First, some key definitions. An antimicrobial agent, substance that kills or inhibits microbe growth, ideally little damage to host. An antibiotic, specific type of antimicrobial, historically defined as substance from one microbe that, in low concentrations, inhibits kills others. So while all antibiotics are antimicrobials, not all antimicrobials are strictly antibiotics.
An ideal antimicrobial drug has several critical characteristics. Should be selectively toxic to the microbe, minimal harm to human host, should be microbicidal, kills target microbe, rather than merely microbistatic, inhibits growth, lets host immune system clear it. Needs to be soluble, potent, not prematurely broken down or excreted. Clinically, for severe infections like sepsis, broad-spectrum bactericidal antibiotics are chosen empirically, based on likely pathogen, before culture results, due to urgent need for rapid treatment.
The genius of antimicrobial agents lies in exploiting unique microbial vulnerabilities. Let's explore key mechanisms of action. First, cell wall synthesis inhibitors. Target bacterial cell wall, structure absent in human cells. Makes them highly selectively toxic. Most common, clinically important class here, beta-lactams. Includes penicillins, cephalosporins, carbapenems, monobactams.
Beta-lactams all share a common chemical structure, the beta-lactam ring, work by binding to bacterial enzymes called penicillin-binding proteins, PBPs. PBPs are crucial for cross-linking peptidoglycan, main structural component of bacterial cell wall. By inhibiting this process, beta-lactams block proper cell wall synthesis, leads to osmotic instability, bacterial autolysis, death. They are bactericidal. Critical challenge. Many bacteria evolve to produce beta-lactamases, enzymes that break the beta-lactam ring, rendering antibiotic ineffective. To counteract this, beta-lactamase inhibitors like labulenic acid often combine with beta-lactam antibiotics to protect them. Other cell wall inhibitors include glycopeptides like vancomycin, which interfere with peptidoglycan synthesis earlier.
Next are protein synthesis inhibitors. Exploit structural differences between prokaryotic ribosomes, 70S, 30S, 50S subunits, and eukaryotic ribosomes, 80S, 40S, 60S. Drugs like macrolides, for example, azithromycin and chloramphenicol, bind to the 50S ribosomal subunit, prevent peptide bond formation, block protein elongation. Tetracyclines bind to 30S subunit, block transfer RNA, tRNA binding, halt protein synthesis.
And aminoglycosides, here example gentamicin, also bind to 30S subunit. But go a step further, cause misreading of mRNA template leads to production of faulty non-functional proteins. These differences in binding sites, mechanisms within bacterial ribosome provide diverse targets for our antimicrobial arsenal.
Then we have nucleic acid synthesis inhibitors, interfere with bacterial DNA replication or RNA transcription. Quinolones, CG ciprofloxacin, inhibit essential bacterial enzymes like DNA gyrase, topoisomerase InV, crucial for unwinding, unlinking DNA after replication. Without them, bacterial DNA replication stops. Rifampin, key drug in TB treatment, works by inhibiting bacterial RNA polymerase, blocking mRNA synthesis.
Finally, we have metabolic pathway inhibitors, target-specific biochemical pathways essential for bacteria but absent or significantly different in humans. Classic example involves folate synthesis pathway. Sulfonamides compete with PABA to inhibit dihydrofolic acid synthesis. Trimethoprim inhibits subsequent enzyme in same pathway, dihydrofolate reductase. Clinically, combining sulfonamides and trimethoprim, as cotrimoxazole, creates powerful synergistic block in this essential bacterial folate pathway, much more effective than either drug alone.
We should also briefly mention other antimicrobial categories. Antivirals are tougher to develop. Viruses use host cell machinery, so targeting them risks host toxicity. Act at various stages, prevent viral attachment, inhibitor for HIV, inhibit replication, a cyclover for herpes, reverse transcriptase inhibitors for HIV, block release, neuraminidase inhibitors for flu. Antifungals typically target unique fungal structures like cell wall, echinocandins, or cell membrane component, ergosterol, amphotericin B azoles, absent in humans.
Okay, now to the most pressing global health threat we face today, antimicrobial resistance, AMR. AMR defined as resistance of a microorganism to an antimicrobial drug that was originally effective for treating infections caused by it. Means standard treatments become ineffective, infections persist, risk of spread to others increases significantly. Crucial to distinguish AMR broader term, including resistance to antifungals, antivirals, antiparasitics from simply antibiotic resistance, specific to bacteria.
Emergence of AMR is a natural phenomenon. Microbes, through random genetic mutations during replication, can develop new traits. If one trait confers resistance to an antimicrobial drug and that drug is present, that resistant microbe has selective advantage, survives, proliferates. Process drastically accelerated by widespread use and, crucially, misuse of antimicrobial drugs, poor infection control, inadequate sanitation globally.
At molecular level, resistance emerges through several mechanisms. Point mutations in existing genes can alter drugs' target site so drug can't bind effectively, or modify existing enzymes like beta-lactamases to extend their activity against new drugs. Bacteria can also undergo macroevolutionary changes like gene rearrangement, or, most alarmingly, acquire entirely exogenous DNA from other bacteria, maybe uptake of free DNA from environment, transformation, or, more commonly, transfer of resistance plasmids or transposons via conjugation or transduction.
And here's the powerful anchor for understanding how bacteria get resistant. Think of bacteria having a cheat sheet for every antibiotic. They develop incredibly clever ways to defeat our drugs. They can. 1. Destroy or inactivate the drug, like beta-lactamases breaking down penicillin. 2. Prevent drug penetration to target site by altering membrane permeability. 3. Alter the drug target site so drug can't bind effectively, e.g. altering ribosomal proteins. Or 4. Develop rapid efflux pumps that just pump the drug right back out before it can work. And here's the scary part. They are incredibly good at sharing these cheat sheets.
Exactly. This sharing or dissemination of resistance genes happens through several mechanisms. Clonal spread. Resistant strain simply selected multiplies. More dynamically, plasmid transfer via conjugation lets bacteria directly exchange resistance genes on mobile genetic elements called plasmids. Resistance also transferred via bacteriophages, viruses infecting bacteria, in transduction process, or uptake of free DNA from dead bacteria via transformation. This horizontal gene transfer is why resistance spreads so rapidly, even across different bacterial species, makes AMR a truly formidable threat.
This brings us to antimicrobial stewardship, AMS. Not just an initiative, but organizational healthcare system-wide approach to promote judicious, appropriate, responsible use of antimicrobial drugs. Goal is clear. Preserve future effectiveness of our existing antimicrobial arsenal, slow down relentless march of AMR.
General principles of AMS. Simple but profound. Prescribe antibiotics only when truly needed, not for self-limiting viral infections like common cold, most coughs, viral sinusitis, earache, sore throats. And critically, always review the continued need for antibiotics after a few days. In primary care, you're on the front lines. Means considering no or delayed antibiotic strategy for acute self-limiting URTIs, using simple generic antibiotics whenever possible, avoiding broad-spectrum antibiotics, coamoxiclav, quinolones, cephalosporins, if narrow-spectrum works. Broad-spectrum increased risk of C. difficile MRSA-resistant UTIs.
In secondary care hospitals, strategy often summarized as start smart, then focus. Means do not start antibiotics without clear clinical evidence of bacterial infection. If infection suspected, use local guidelines for prompt, effective treatment. Crucially, always document indication for antibiotics, plan duration, review date, route, dose. Vital to obtain cultures, blood, urine, sputum, etc. before starting antibiotics. Results allow you to narrow therapy later, treat resistant bugs, or even stop antibiotics if no bacterial cause found.
And the then focus part. By 48-72 hours, must review clinical diagnosis and ongoing need for antibiotics. Review leads to actions. Stop antibiotics if no infection. Switch forward to oral. Change to narrow spectrum or different antibiotic. Continue if appropriate. Consider outpatient parenteral antimicrobial therapy, OPTIC. Must document this review and decision. Clinical relevance for you as future doctors? Immense. You are on the front lines against AMR. Your individual prescribing habits directly impact public health. Future effectiveness of these life-saving drugs for everyone. Profound responsibility.
We've covered a vast microbial landscape. Now we arrive at part 9. The evolving landscape, emerging and re-emerging diseases. Microbial world isn't static, constantly changing, throwing new challenges our way. Emerging infectious diseases, newly identified in a population, or recently increased in incidence or geographic range. Examples: Ebola, SARS, MERS, SARS-CoV-2, COVID-19, Zika.
Re-emerging infectious diseases. Known diseases, previously under control, maybe thought eliminated, now making unexpected comeback, often due to change in circumstances. Classic examples: tuberculosis, measles, mumps, malaria. To anchor this, think emerging diseases as brand new villains appearing. Re-emerging diseases are old foes making unexpected comeback, often because we've let our guard down or conditions changed in their favor.
So how did these infections emerge? Typically involve sequential process, agent introduced into new host population, often from animal reservoir, zoonosis, then becomes successfully established, transmitted within that new human host population.
Yep.
Striking statistic. Estimated 60–80% of all emerging infections are animal-derived. Underscores critical link between human and animal health. One health concept.
Many factors contribute to this dynamic threat. Microbial adaptation is paramount. Mutations, AMR acquisition, immune evasion. Ecological changes play a huge role. urbanization, deforestation, bringing humans into contact with new pathogens, climate change creating vector-friendly conditions, dengue, malaria. Healthcare technology, while beneficial, can contribute. New procedures, transplants, blood transfusions.
Globalization, rapid international travel trade, lets diseases spread across continents in hours. Public health breakdowns, inadequate sanitation, low vaccine coverage create fertile ground for reemergence.
Yeah.
Plus, increased host susceptibility in populations, elderly, malnourished, immunocompromised, alongside relentless rise of AMR, changes in human behavior, sexual contact, drug use, mobility, all contribute to this evolving landscape. Global surveillance, robust reporting of notifiable diseases, Ebola, TB, measles, mumps, to public health agencies are crucial early warning systems.
Let's briefly review a few global case studies to illustrate these points. Ebola, caused by Ebola virus, negative sense ssRNA. Severe viral hemorrhagic fever. Symptoms, 2 days, 3 weeks post-infection. Fever, severe muscle pain, headache, vomiting, diarrhea, decreased liver kidney function, often leading to internal-external bleeding.
Ebola spreads via direct contact with body fluids, blood, semen, breast milk, feces, vomit, saliva, urine, from infected people, contaminated items. Fruit bats considered natural reservoir. Pathophysiology. Virus replicates in monocytes, macrophages, dendritic cells. Spreads to lymph nodes, liver, spleen. Triggers massive pro-inflammatory cytokine release. Leads to endothelial damage, reduced vascular integrity, coagulopathy, DIC, hepatic impairment. Management. Immediate isolation, aggressive supportive care, fluids, electrolytes. Increasingly specific antivirals, monoclonal antibodies. Ring vaccination for outbreak control.
We've discussed tuberculosis and measles before, but important to re-emphasize their status as re-emerging infectious diseases. Global efforts to eliminate measles face significant setbacks. Decreased vaccination coverage, partly worsened by COVID-19 pandemic. Similarly, mumps, another re-emerging RNA paramyxovirus, causes salivary gland swelling, parotitis, can lead to complications. Epididymoergitis, testes inflammation, meningitis, rarely deafness, or pancreatitis.
Coronaviruses provide a stark lesson in emergence. SARS, severe acute respiratory syndrome caused by SARS-CoV, China 2002, international outbreak 2003, fatality 10%. MERS, Middle East respiratory syndrome caused by MERS-CoV, acute viral respiratory infection, camels, primary animal host, high fatality 35%, and of course COVID-19 caused by SARS-CoV-2. Global pandemic 2020, spectrum of severe respiratory illness, long-term complications. These viruses show rapid potential for zoonotic spillover, global spread.
Lastly, avian influenza A, specifically highly pathogenic strains like H5N1, H7N9, contagious viral infection in birds, occasional human transmission. When it jumps to humans, can cause severe pneumonia, ARDS, high mortality. Patients typically present cough, severe flu-like illness, dyspnoea, fever. Diagnosis tricky, clinically indistinguishable from other severe respiratory infections, needs specific PCR tests. Treatment focuses on antivirals like oseltamivir, supportive care, antibiotics only for bacterial co-infections. Prevention hinges on rigorous hygiene, respiratory etiquette, early self-isolation, avoiding direct contact with infected birds, contaminated environments. Hashtag outro.
Wow. Okay, we've truly journeyed through an immense microscopic world today, haven't we? From meeting the tiniest viruses and bacteria to unraveling their cunning invasion strategies, understanding how our bodies sometimes fight back too much in sepsis, dissecting those unseen toxic weapons, exploring our inner microbial cities, and finally grappling with the relentless challenge of antimicrobial resistance and emerging global threats. You really should now have a powerful foundational framework for understanding infection, connecting these seemingly separate parts into a cohesive clinical picture.
Absolutely. And remember, in medicine, knowledge isn't just about memorizing facts. It's about connecting the dots, recognizing patterns, and understanding the why behind every symptom, every treatment you encounter. This deep dive isn't just theory. It's designed to be a robust toolkit for the complex, real-world clinical scenarios you will face. It's about building that mental model that lets you confidently assess, diagnose, and act.
So, as you continue your journey to become a clinician, here's a provocative thought to carry with you. Given how quickly viruses and bacteria can adapt, how easily global travel spreads these changes, how rapidly resistance can emerge, what responsibility do we as future clinicians have? Not just to treat existing diseases, but to truly understand, anticipate, and maybe even prevent the next microbial challenge before it even emerges.
Your learning journey in infectious diseases has only just begun. Stay curious, stay vigilant, and never stop asking why it matters for your patients.